Inside intensive and long-term care environments, managing critically ill, immobilized patients involves high-stakes variables. Nutrition is frequently relegated to the background. A severe grade 4 pressure injury represents a massive biological deficit. These wounds often stagnate because systemic inflammation, prolonged immobility, and profound catabolic stress combine to arrest the body's natural tissue repair mechanisms. A common misconception in clinical practice is that calculating a daily caloric target and running a static feeding formula will reverse this catabolic state. Standard polymer formulas deliver fixed macronutrient ratios. When a highly compromised patient experiences rapid shifts in metabolic demand and gastrointestinal tolerance, a rigid set-and-forget prescription becomes actively detrimental. Effective enteral nutrition for advanced wound care requires a different approach. It must be executed as a highly dynamic, individualized therapeutic intervention. A 2026 case series published by Antony and Ayesh examines exactly how this intervention looks in practice. It provides a blueprint for how advanced clinical dietitians operationalize abstract nutritional guidelines from ESPEN and ASPEN. The authors followed 4 critically ill adults. Each patient carried a complex history of comorbidities, ranging from hypoxic ischemic brain injury to Alzheimer's disease, alongside prolonged immobilization and advanced non-healing pressure ulcers. Routine indirect calorimetry was unavailable. The clinical team had to rely entirely on rigorous physical assessments, continuous weight monitoring, and validated equations to estimate caloric requirements. The intervention relied on 3 core pillars: safe feed initiation to prevent metabolic collapse, the integration of targeted immunonutrition, and continuous multidisciplinary titration. The utility of this case series lies in its practical mechanics. It demonstrates how theoretical best practices transition into functional, adaptable bedside protocols for patients operating at the edge of biological failure. This patient dashboard tracks Case 2, presenting with severe protein energy malnutrition. Rapidly introducing caloric targets could trigger fatal refeeding syndrome. To prevent cardiovascular collapse, the team continuously monitored serum electrolytes. They initiated early feeding via nasogastric tube at a minimal rate, staging escalation over 8 weeks. Early enteral feeding was prioritized over parenteral intravenous routes. Using the gut, even at a fraction of the caloric target, maintains intestinal barrier integrity and reduces the risk of systemic infection. In highly catabolic patients, safe initiation demands prioritizing metabolic stability and electrolyte balance over the rapid pursuit of gross caloric goals. Protein targets were aggressively pushed once tolerance was established, reaching up to 2.8 grams per kilogram of body weight in Case 2. Standard macronutrients alone, however, lack the specific substrates required to physically close a grade 4 ulcer. This cellular schematic illustrates the specialized immunonutrition supplement deployed for impaired wound healing, adding 3 elements to the baseline formula. Arginine and glutamine act as essential precursors for collagen synthesis. Meanwhile, Cal-HMB distinctly mitigates muscle protein breakdown, preserving lean mass in chronically immobilized patients. The authors issue a vital clinical caveat. This triad is a selective, targeted adjunct for severe depletion. It is not an uncritical default intervention for every patient in the ward. Delivering these specific nutrients requires continuous reassessment. The dosage and duration must be calibrated in real time, alongside the intensive care and medical teams. Architecting tissue repair requires supplying precise biochemical building blocks. At this level, the enteral feed operates as active pharmacological support rather than basic sustenance. This 10-month timeline tracking Case 4 dispels the assumption of static prescriptions. After 8 months of tolerating a standard polymer formula, gastrointestinal intolerance occurred. The team immediately pivoted to a specialized hydrolyzed formula, carefully stepping down intake targets until reaching a stable maintenance phase. Long-term wound healing demands rigorous monitoring of gastric residuals and the agility to completely rewrite the nutritional prescription mid-treatment as the patient's physiology dictates. This comparative outcome grid maps the clinical trajectories observed across all 4 patients over the follow-up period. Through continuous titration, the dietitians achieved massive protein delivery. Case 3, for instance, successfully scaled up to tolerate over 112 grams of protein per day. The ultimate clinical outcome was uniform: every patient in the series transitioned from an advanced, non-healing grade 4 pressure injury to completely healed status within 10 to 12 months. The exact pace of recovery varied due to individual comorbidities, but the overarching trajectory of weight stabilization and progressive tissue repair remained consistent. When enteral nutrition is progressively optimized and highly individualized, even deeply compromised patients achieve positive wound healing outcomes. As an observational case series without a control group, the Antony and Ayesh report contains a critical scientific limitation. It cannot offer absolute causal proof that the nutrition alone healed the wounds. This network graph models the clinical reality. Nutrition acts as a biological catalyst, but it requires an integrated supportive framework to function. Delivering optimal protein and immunonutrients achieves nothing if the physical pressure on the damaged tissue is not simultaneously offloaded by the nursing team. The case series does not attempt to establish independent causal efficacy. It provides real-world, practice-based evidence of implementation. The directive for clinical practice is clear. Managing advanced pressure injuries demands formal, dietitian-led physical assessments, not generic feeding orders. Optimizing wound care means treating dynamic, targeted enteral nutrition as one essential pillar of a comprehensive medical strategy.